For those of you that don't know me, my name is Sharon Hovland. I am a fellow LAM patient. I was diagnosed at Mayo Clinic about 14 years. It'll be 14 years next month that I was diagnosed. I am also the volunteer LAM liaison for Region 12, which includes the Dakotas, Minnesota, and Wisconsin. And I've been coordinating this Q&A session for the past 7 years. Started out as a one-off during COVID and has become an annual event. I am joined today by two members of our LAM Foundation team, which many of you already know. Erin Williams is our patient outreach coordinator, and Cindy Beasley is the Director of Education and Advocacy. They will be managing our Zoom meeting for us today and keeping track of the chat box and any topics that come up that we need to follow up on later after this session. And a big thank you to both of you for giving up your Saturday mornings to be with us today, and to the LAM Foundation for continuing to support our educational sessions. As you can see, we have a great representation of the LAM community with us today. All of us that are living with LAM, our friends, our families, the LAM liaisons from multiple regions in the United States and Canada. And we have three of our very hardworking and dedicated LAM clinic directors who I have the chance to introduce to you today. So first up, we have Dr. Baqir, and she's been part of these meetings since we started them back in 2020. She is an associate professor at Mayo Clinic, where she serves as director of the LAM Clinic and program director of the Interstitial Lung Disease and Vasculitis Fellowship. She completed her fellowship in pulmonary and critical care medicine at Emory University, followed by a fellowship in interstitial lung diseases and vasculitis at Mayo Clinic. Her clinical and research interests focus on autoimmune diseases associated with interstitial lung diseases and on the pharmacological treatment of pulmonary vasculitis, with a strong emphasis on advancing specialized care for patients with rare and complex lung conditions. Next, we have Dr. Gupta, and he's been participating in the event since 2024. He's a professor in the Division of Pulmonary, Critical Care, and Sleep Medicine at University of Cincinnati, where he serves as the director of the Interstitial and Rare Lung Diseases Program. Dr. Gupta's clinical and research focus is in the field of rare lung diseases such as LAM, and his work is aimed at better defining the natural history, improving detection, and developing novel treatment modalities and monitoring strategies for patients with LAM and other rare lung diseases. Dr. Higuero-Sevilla is joining us for the first time this year. He is an assistant professor in the Division of Pulmonary, Critical Care, and Sleep Medicine at Yale School of Medicine. He is a member of the Yale Interstitial Lung Disease Center of Excellence and serves as the Associate Program Director for the Pulmonary and Critical Care Medicine Fellowship. He founded the Cystic Lung Disease Program at Yale and is the director of the Yale LAM Clinic. His clinical and research interests include a focus on connective tissue disease, associated interstitial lung diseases, and cystic lung disease. Thank you to all three of you for being here today and for all the time you've put into preparing and spending with us this morning. As you know, we asked for questions and topics for today in advance, and the doctors have had a chance to look at them. We got a good list, and we are going to start with Dr. Gupta, who's going to be covering several of the research-related topics that you asked about. So first off, Dr. Gupta, can you please tell us about LAM research developments, particularly those focused on slowing progression, targeting or eliminating LAM cells, repairing lung damage, and potentially moving us closer to a cure?
Yeah, thanks, Sharon. And morning, everyone. Thanks for taking some time out on your Saturday for this. I'll, in the interest of time, try to be brief and try to be overarching and general rather than specifically targeting single things here, but hopefully I'll still cover it in its full breadth. So as everyone knows, so far, from a treatment standpoint, the focus has really been on targeting this mTOR pathway. That's the central growth signaling pathway that is abnormal, that drives the growth and proliferation of LAM cells. That has led to the discovery and now widespread availability of sirolimus as a treatment for LAM. Now, as we go from here to the next steps, as we think about how to induce remission, how we think about the ultimate goal of cure, there are developments in different domains. So one is that we need to think about, are there ways that we can target this mTOR pathway better? Meaning, can there be more specific, more high fidelity drugs better than sirolimus that can fully target all aspects of this pathway? That sirolimus is targeting some of it, but not all of it. And there have been some recent discoveries then in the development of compounds that can do that. So that by itself is probably the most exciting finding in that it is targeting the central pathway. Beyond that, we are also now need to look at, we know that the abnormal cells are not doing everything by themselves. They are now attracting other things, other cells, other pathways, and together they are causing this sort of progressive damage to the lung. And by using novel technologies that allow us to study LAM at a high resolution in human lungs, we now have a better understanding of what are some of those immune cells that are being attracted by the lab cells. And the knowledge on that pathway means that we can now target that, and that can be in addition to something that rapamycin or sirolimus is doing by itself. We have a better understanding of how LAM cells are evading detection by the immune system that is there to sort of detect these things from growing. And that also provides strategies for treatment. The discovery of potential synergy with the uterine signatures perhaps has rekindled the interest for hormonal therapy in LAM. And I think that is another avenue. And so if you put it all together, right, we are now thinking about not only the mTOR pathway, but what are the other pathways that the LAM cells are using to communicate with other cells. And I think all of them provide very useful leads for future trials.
Right. The next, is there any research underway exploring the possibility of growing new lungs using stem cell technology?
Yeah, that's a good question. Is there research along the lung regeneration aspect? Absolutely. Is it something worthwhile? Is it something exciting? Is it something that the community should be going for? Absolutely. Is it ready for prime time yet? Not close. And the other thing of a note here is that that is something that is unique, and that's not unique to lab, right? That lung regeneration uh, is relevant to a variety of lung diseases, including more common lung diseases. So I think as that technology develops, emerges, we come closer, it is likely going to be tested and first applicable to the more common lung diseases, and we can learn from that and then try to apply it towards lab.
Right. Are there any ongoing or upcoming research studies enrolling LAM patients? How can patients find information about available studies and learn whether they meet the eligibility requirements?
Yeah, that's a very good question. I think as before even answering the question, something that I would like to make a plug for, and the LAM community is we probably don't even need to make a strong plug for it, but the way we come to new therapies, even if we go back to the first question, how do we find a cure? How do we develop new therapies? Well, we can do all the science we want, but a new therapy is not coming until and unless we can test it in the clinical trial. And so that is the exact and the right question that every single patient should be thinking about and should be asking their clinic directors or their clinicians as they are going. How can I contribute to research? How can I contribute to trials? Again, I don't. The LAM community has been very motivated and very generous on that aspect, so I don't need to give a long lecture on it. But I still wanted to at least get that point across. To answer your question. At this point, I am not aware of an enrolling clinical trial in LAM. That is something that I think we do need to change, because I would like to uh, reach a situation, a stage where there is always at least one clinical trial open and enrolling for patients with LAM. I think there are some targets that are ripe for translation. I think those targets we should take to trials. I'm aware of a couple of those targets being thought about for trials. We ourselves are working on one or two targets and hope to start enrolling those trials soon. But at this point in time, I'm not aware of an open enrolling trial. That doesn't mean that that doesn't exist one. And the last bit of this question was, where can patients find this information? I think the LAM Foundation is a really good resource for it. There is a section on the website where you can look at the open enrolling trials. Clinicaltrials.gov is another useful website where you can search for open trials. And you can always call the LAM Foundation for information as well.
So Cindy and Aaron, maybe we can get those links pulled together and send them out to the group after the meeting with the recording.
Yes, of course.
Thank you. If a patient is interested in contributing to research through post-mortem donation, what steps should they take?
Yeah, well, first of all, thanks for even thinking about that. That gesture and that ask is always appreciated. I think first is that if you know that there is going to be an upcoming procedure, and I'm gonna take it not only just postmortem, but a procedure such as you are going to have a lung biopsy or you have a kidney tumor that is going to get taken out for whatever reason, or you're undergoing transplant. Those tissues are very valuable in that they are not easy to come by. It's a rare disease, as everyone knows, and studying the disease directly from human tissues is very important because there is no gold standard animal model that exists for LAM. There is a partnership that the LAM Foundation has with the NDRI, which is a federal agency running out of Philadelphia that can help us collect those tissues and distribute to the LAM scientific community widely. So if you know that some such procedure is going to happen or that you're going to be getting a transplant, please get in touch with the LAM Foundation so you can have that paperwork completed with NDRI so that that tissue becomes available. Now coming to the specific question of post-mortem donation, generally for most research purposes, we are looking for viable tissues to where post-mortem tissues may not be that relevant specifically for LAM research. Now that doesn't mean that there can't be other uses for it. A lot of times medical schools are using those tissues for general education. So if specifically thinking about post-mortem donation, that may be another avenue that perhaps your local clinician can help you connect with the medical school for.
Very good. And then finally, what would you consider to be the major milestones in LAM research in the last 15 years?
Okay. Well, 15 years, that's interesting that the time frame chosen is 15 years, because if you think back to it, the New England Journal publication for sirolimus and LAM was in about a month and a half. It will be 15 years. So it actually just barely met the 15-year timeline. The reason that's important, though, is that we always want to keep moving ahead with urgency, but sometimes we lose sense of the perspective that this landmark trial, this therapy that is FDA approved, that works remarkably well for the vast majority of patients with LAM, this is just barely 15 years old. And so first and foremost, I'd highlight that as a major milestone over the past 15 years is the fact that we prove the safety and efficacy of sirolimus. On the same vein, I think over the past decade or so, we have realized how sirolimus is not only effective at controlling lung function decline, but is remarkably effective at controlling Tachyllus complications, helps shrink kidney tumors, helps reduce and prevent pneumothoraces, and has recently also been shown that helps women with LAM live longer. So I think that probably is the biggest milestone is all the benefits we have seen from sirolimus and LAM. Other things I'd highlight here are that we have a set of guidelines that help us diagnose and manage LAM in a very uniform, consistent manner. We have a worldwide network of clinics that help us provide quality care, become sites for collaborative studies and trials. We have regulatory approval for sirolimus in 40 plus countries across the world. And the last thing I'll highlight here is the use of this emerging technologies like single cell and spatial transcriptomics that is allowing us to understand human LAM at a resolution that we previously never thought was possible. And that is helping us uh, evaluate a number of new biomarkers, a number of new therapeutic pathways and candidates uh, that bodes well for the future in terms of future drug discovery and biomarker discovery.
Great. Yeah. I was diagnosed 14 years ago, and it feels like there's been a lot of progress and a lot of hope in that amount of time. So thanks for highlighting those. Dr. Higuero-Sevilla, this one's for you. I've heard LAM compared to cancer, and that feels frightening. Is that an accurate way to think about it? And how should patients understand that comparison?
That's actually an excellent question that has been a matter of debate within like LAM researchers and LAM clinicians. It's funny because even when I was a resident that ended up getting involved in ILD, I remember one of my mentors was part of like a group of editorials that were debating this very same question more than 10 years ago. So, but it all comes from what is in a name, right? The stigma that comes with the word cancer and how LAM, interestingly, has some of the things that we come to think of as cancer, but is not really well defined within it. LAM is actually better defined as in medical terms what we call a neoplasm, which like layman terms would be say a tumor. So it's an abnormal proliferation of cells, tissue, and then interesting LAM has some features that would go along with what we think of a malignant tumor in the sense that it can metastasize, it can go to other organs, it can evade the immune system. However, it also has, when it's looked under a microscope, it looks like more of a benign tumor. And the evolution of LAM is restricted to what organs it goes to. It actually will take years to decades to progress. So from a biological standpoint and from our terms for research purposes, does it have some features of what we think of as a malignant tumor or a cancer? Yes, but what it means to the individual patient and like the fear and stigma that we associate with cancer, you should not think about it that way because it does not fulfill those criteria. It actually is not restricted to where it's going to spread. We know that behavior can be indolent, take years or decades to grow. Some people will argue that the benefit of thinking about it, that we treat it as a more serious condition, recognize the severity of the complications that can arise from it, and people will be more eager to test possible therapeutic agents and medications that might have some risk of side effects because we're treating it more seriously and more willing to explore about it. But with that comes the fear of naming it that way. So I would say it is a tumor that defines the traditional classification, what we think as benign, as malignant. But for the individual patient, it is not a cancer. You should not think about it that way because it's gonna cause unnecessary fear when it's has a very different disease behavior over time, which is what you're about.
you. That's a helpful explanation. And then aside from being female, are there any other common traits or characteristics shared by people with LAM?
So yeah, so of course, gender is the big thing. Lyme is a disease almost exclusively of women. Other things that we share for most cases with Lyme are how does it present? When does it present? So it will be usually around 30s and 40s. And a common trait is that you're going to present with respiratory manifestations, either progressive shortness of breath that has been maybe misdiagnosed as asthma in the past, or presenting all of a sudden with a pneumothorax. The hormonal relationship of variation of symptoms with menstrual cycle, like issues with high periods of estrogen, like pregnancy, can be are things that are commonly shared. Biologically, like in the underlying biology, all the women with LAMS share that tuberous sclerosis gene mutation, but presentation, I would say those are the factors that they share, like age, hormonal relationships, respiratory involvement.
Okay, great, thank you. Dr. Baqir, can you tell us what percentage of LAM patients experience lung collapses?
Good morning, everyone. So from the guidelines that Nishant mentioned about the guidelines and the ATS and the Japanese Respiratory Society came up with, they quoted this pooled number is 57%, and that is based on 7 different case series. So it would be around 57%, not exactly 57%. So 57% of females would develop pneumothorax. This is their estimate. The recurrence rate, on the other hand, if somebody has one pneumothorax, the recurrence rate is around 70% in females. And if we look at if you have one pneumothorax, the chances that the same person would have another pneumothorax is quite high. And the estimated number of pneumothoraces is on the average 4 per affected patient.
Okay, good to know. And this one's about stability. When clinicians describe a LAM patient as stable, what does that truly mean? If lung function continues to decline, albeit slowly, can that still be considered stability?
That's a very good question, I would say. So in order to answer that question, we have to understand the rate at which the lung functions decline, even in a normal person without any lung issues. So in a healthy person, the rate of decline of FEV1 is around 25 to 30 ml per year. And that happens because with age, there are changes in the elasticity of the lung and the chest wall. And some people say that even the small airways or bronchioles change with age. So in untreated premenopausal LAM patients, this rate of decline, which is 25 to 30 ml in a healthy person, is about 89 to 118 ml per year. And for sake of simplicity, we can say that 90 ml on the average, 90 ml per year decline. And in postmenopausal women, this rate is about 40 to 74 ml per year. So this is to give some background that in number terms, that what we are talking about. So when we say stability in lung functions, we want the lung functions to be, we expect some decline as even normal person decline, but it is near normal or in between. Like I would say if it is between around 40 ml per year, we would say that, okay, lung functions are stable. The MILES trial that showed that FEV1 actually increased by 1 ml per month during the treatment. And the ladies who were on the other trial without treatment, they lost about 75 to 120 ml per year. So this gives you an idea that how these numbers work. So the real question is that how to distinguish between a physiologic decline versus pathologic worsening of the disease. So when we look at the numbers, we look at the graph of FEV1, when you come to our pulmonary function test lab, we are looking at what rate it is declining. And in our pulmonary function test lab, they have also given us this reference range that with this age, with this race, with this height, the person should be declining at this rate. So we look at that rate to compare that is it under the expected limit, or is it, say, for example, if somebody has, first of all, it's not only one PFT value that we go by, we look at the trend. But if it is like around 75 ml per year, then we know that the rate is more than what we would expect to decline. So that's how we look at the things. That things get a little tricky when FEV1 is stable, but sometimes diffusing capacity or DLCO is declining. That is also another caveat to look at. So just imagine that this would be if the smaller cysts are breaking down and they have greater surface area, they might contribute to decrease in diffusing capacity, whereas the larger cysts are okay and that FEV1 is stable. That is another thing that we need to consider when we look at the PFTs.
Thank you. And then related to that, how should patients interpret long-term declines in PFTs while on sirolimus? And how do we know whether the medication is slowing progression versus not helping?
Yeah, I think that question is also linked to our previous discussion, the previous question. But the analogy for patients to understand is that just imagine that your roof is leaking, and at what rate the roof is leaking. So say, for example, in a lamb lady, it is 3 buckets per hour, whereas we give sirolimus and now it is leaking at 1 buckets per hour. So the leak is still there. The mutation that is causing the disease is there. We are not fixing the real problem, but by sirolimus, we are putting kind of brakes on the process. We are trying to slow down the process of decline. So as I mentioned before, that we look at the rate, that whether the rate is within the expected limit or is it more than expected? It is at the rate of untreated premenopausal ladies, or is it at the rate of somewhat near normal person? So that is what we are expecting. But when we start sirolimus and the slope of decline kind of flattens, and we have converted the steepness of the slope of decline to somewhat slow decline or slower decline, that is success for us. And if there are fewer pneumothoraces as compared to before, if the chylous effusion is accumulating less, or there is stable CT cyst burden, or there is stable oxygen requirement, these are the things that we look for usually when we put somebody on sirolimus to see if the drug is working. What patient needs to understand is that stability is not equal to no decline. There would be some decline, and that, as I mentioned, also happens in normal people. And small decline can happen with normal aging, and it is the slope that matters, at which rate that is declining. For example, if pre-sirolimus, somebody was declining at a rate of 90 ml per year, now it is 30 ml per year, that is a huge success in our mind. So converting a steep slope into a gentle one is what we are looking for. And as I said before, if the rate is like 75 or 100 ml per hour of decline, then we know that the drug is not working.
That's helpful. Thank you. And then one last question for you, Dr. Baqir. How reliable is the VEGF-D test in diagnosing LAM? And if a patient's VEGF-D level is higher, does that correlate with more severe disease?
Another very good question. So VEGF-D stands for vascular endothelial growth factor, which is actually lymphangiogenic growth factor. And it is secreted by LAM cells, and it reflects lymphatic involvement. LAM cells secrete this factor, and it levels rises in the blood when patients have LAM. The question is that how, if the level is very high, how would it predict the severity of the disease? So the short answer is not reliably. We have to consider LAM as having 2 components. So one is that you have this LAM cells, they secrete certain chemicals which break down your tissue matrix, and that causes cyst destruction. That is what we measure on FEV1. We looked at CT scan, and that is what and even DLCO, that is what we are looking at. But the second component of LAM is this, I think Dr. Lisa, what is her name?
Lisa Hensky?
Hensky? From
Boston.
Lisa
Hensky, right?
Lisa Hensky, sorry. In her paper, she has used the term frustrated lymphangiogenicis. And I think that is what it is. So the second component of LAM, other than cystic destruction, is that you have this abnormal lymphatic signaling activity. So it is like these VEGF-D are like GPS for these lymphatics. They tell you that there is new formation of lymphatics, but they are leaky lymphatics. They're not the best lymphatics, and they help LAM cells to migrate from one place to another. So therefore, the VEGF-D is actually telling us that component of LAM, the lymphatic or LAM cells activity in the lymphatics. So whether this will tell you about the severity of damage, probably not, because this is showing you that what is the LAM cell burden in lymphatics. It will show you about the chylus formation, chylus ascites, and lymphatic problems rather than the cystic destruction. So I would not say that how high your VEGF-D would correlate with the lung functions.
Okay, good to know. Dr. Gupta, I've heard other patients mention cyst scores. Could you explain what a cyst score is and how and when is it done?
Yeah, so a cyst score is, simply speaking, a way to just quantify what percentage of your lung is occupied by cysts on a CAT scan. So if you why is it being developed, or what its potential values maybe. If you think about it, so far we've been talking about lung function. You hear a lot about FEV1, etc. So that's a indirect measure for us to track what someone's disease severity might be, how fast they might be progressing, and how well they might be responding to treatment. Now, intuitively speaking, if you think about it, if we say that the damage in LAM is happening because of cysts developing in the lungs, and these cysts are things that we can see on the CT scan, it is quite intuitive to say that, oh, why can't we just count these holes and see what percentage of the lung they're occupying? And that would tell me if I have mild disease, moderate disease, severe disease, and we can count them over time and see what's happening to the disease progression or what might be happening to treatment. That makes a lot of intuitive sense. But if that is the case, why is it not being used very regularly? A couple reasons. One is that while a lung function test, as cumbersome as it might be, and I often joke with patients, say that's the only fun we have, it's radiation free. But every time you do a CAT scan, there is a little bit of a radiation dose that you get. It is getting better and better, but still, that is a concern. The second, and perhaps the more relevant concern, is that while we've been able to show lung function decline as an efficacy measure, we haven't really been able to show that longitudinal measures of cyst scores track very well with either lung function or quality of life to be used as a sensitive endpoint for trials. I think there is still some value here to where it needs to be explored further, but it is not ready for prime time to where every patient needs to get their cyst scores ascertained, measured, or followed on a longitudinal basis. So long story short, if someone is out there wondering that they're missing something because they don't know their cyst score at this point in time, that you're not missing anything.
All right. And you brought up CT scans. The next question is about being concerned about the radiation exposure from repeated scans, and if there's options for lower dose scans that they should be talking to their doctors about.
Yeah, so the radiation exposure from CT scans is getting lower and lower by the day as this technology improves. And in general, even though we mention it, we think about it, in the grand scheme of things, the risk of radiation from a single CT scan is actually really, really low. If you think about it, the average radiation from a CT scan is probably equivalent to you living your life and getting background radiation for about a year. Now the low dose CT scans that are commonly used for other situations like lung cancer screening, etc., those cut the radiation exposure by about half. They haven't been systematically studied. Hey, will that still be high resolution enough for us to uh, very sensitively look at the lung parenchyma? But I'll at least give my bias is that after the initial CT scan, a lot of times you're just looking to get gross estimations. Is there a problem? Is there a complication? How does this look, etc.? And for most of those purposes, I think a low dose CT scan is sufficient. So whenever possible, at least at our institution, we are trying to say, can we just get by with a low dose CT scan? And I think that's a question worth asking your clinicians as well, especially for follow-up scans, if they could be done with low dose protocols.
Good to know. Thank you. Dr. Higuero-Sevilla, we have several sirolimus questions for you. First, we have a patient that said she's starting sirolimus soon, and she's feeling very nervous about beginning the medication. And she asked what guidance you can offer patients starting sirolimus.
So the first thing I would say is I would provide reassurance that for the most part, our patients tolerate sirolimus well, and that's something that we have learned from the Miles trial and even on follow-up. And the more we use it, the more we realize that most patients, what they will experience, if any, are mild side effects. A lot of the older literature of side effects on sirolimus was in the use on the transplant world, and now we even know that even lower doses are effective to control most patients. Like the most common side effects that are seen usually are like oral ulcers, maybe some diarrhea, some nausea, high cholesterol, uh, swelling in the legs, or rash, which none of them sound very pleasant, but are things that we can manage. And once you start sirolimus in a lab clinic, you're like there's a team. It's not only your lab clinician, but normally we have pharmacy and resources to guide you about how to how to take this medication, what to do. We always offer in our clinics guidance to the patients. Like if you have a fever, stop your medication, call us. If you're going to get surgery, which I know there's a follow-up question about that, what to do. So for the most part, people tolerate their sirolimus well because this is a medication that now we know people can be taking it for years and tolerate it without major side effects. Even the question of, well, it's a medication that lowers your immune system and it can increase your risk of infections. Interestingly, in like the Miles trial, there were less respiratory infections in the patients that were taking treatment. And even on a follow-up larger study, which was a pool of data, meta-analysis, there was no evidence that using sirolimus increased respiratory infections, and there was actually some suggestion that it, if anything, was protective. So I'll say most likely you'll be fine, and any side effects we can manage.
Okay. And I know when I started it 14 years ago, I had some of the side effects, the mouth ulcers, acne, really bad acne, but it was for a few months up front and then resolved itself. You know, we did some things to help relieve the symptoms, but after a few months, I was really pretty much symptom free. So I don't know if that's common, but just my 2 cents worth on it. Okay, the next one is
And if I might add there as well, sorry, the thing is breaking up here. Hopefully everybody else can hear me okay. What you mentioned is a very good point, is that the side effects tend to be more common in the first few months and then they settle. And as JP has also said, that a lot of the side effects are also dose dependent. So
yes. Oh, yes, that's true. When I had the chylothorax, Dr. Baqir, I did go through symptoms again when we raised my dosage. So, yeah, I can understand that. Okay, next question. When taking sirolimus, how often should blood levels be monitored, along with labs such as complete blood count, comprehensive metabolic panel, lipid panel, and additionally, how frequently should lung function tests be performed while on the medication?
Okay, so I will say that for the most part, there might be some variability clinic to clinic, but there is a general practice is so for the sirolimus levels, once you start sirolimus, and we usually start with a low dose, like for the most patients, we start with a low dose of 1 milligram, and you should check levels 2 to 3 weeks after starting the dose. I usually counsel my patients to get used to taking the sirolimus at the same day, at the same time every day, and that when they're gonna get their trough level checked, that they should get the the blood drawn 24 hours after 24 hours after their last dose, and just before they take their new dose, so to make it more accurate. So, and normally we want the level to be like below 10, which is nanograms per. Uh, if you don't make any changes to the dose, I usually check it every 3 months. Now, if there's any adjustments, then you're gonna have to check it again every 2 to 3 weeks after. Then the rest of the monitoring blood work, which is gonna be we'll call a CMP, which is liver and kidney function, blood count, a CBC, a urine analysis, a lipid panel, check your cholesterol, your triglycerides. We're gonna get one at baseline, and on average, like every 3 months, at least for the first year, uh, just to make sure that you're not developing any side effects from sirolimus that we want to catch early.
Okay.
And
Right.
the lung function. So for the lung function, I usually get lung function at baseline. The parameter that we monitor the most closely is in your spirometry, is the number called the FEV1, and we want the FEV1 done after bronchodilator therapy, so after you get albuterol. And we'll check that at baseline, and then at the beginning, like the first year at least, every 3 to 4 months. I also check something called diffusion capacity every 6 months at least. And then it all depends on stability. If it's somebody that achieves the stability and is doing well, then you can space out the frequency of the lung function testing to every 6 months the second year. And then if they've been stable for a long time, then you can say, okay, we'll just do yearly testing. But again, that depends on how you're doing with your disease scores. And there's gonna be some variability between clinics, but that's just should be okay. Like for the most part, those are the guidelines that we use.
Okay. And then the question that you brought up about surgery. If a patient is scheduled for surgery, how far in advance should sirolimus be stopped? And then when is it safe to restart?
So on average, we ask patients to stop their sirolimus 1 week before elective surgery, and then they can restart it a week after surgery. But I make the caveat that we say on average a week after the surgery, but that is if they have achieved proper wound healing. So the concern is that sirolimus is gonna impact. So if it's a surgery that went fine, that you already checked in with your surgeon postoperatively and everything is going as expected, 1 week is probably fine. Somebody that has a complicated postoperative course might need to wait longer. So that would be a discussion between your lab clinician and your surgeon.
Okay. And the final question for you. I've heard that GLP-1 medications for weight loss may be safe for LAM patients who are taking sirolimus. Have you seen any concerns or complications with this combination in your patients? And are there any particular side effects specific to LAM patients that we should be aware of?
That is the use of GLP-1 medications. I actually had a patient ask me that question a couple of weeks ago, and for the most, like I looked it up, and I have not heard anybody bring it up, but I looked up any research about it, and there's no evidence that I found so far that there would be an interaction. And like at least biology wise, like the mTOR pathway and what GLP-1 does, it actually can potentiate, it can impair. So there's not like a one-sided relationship that we could imagine doing something for or against LAM. So I told my patients it's okay to use particular side effects. So the most common side effects with GLP-1s are gastrointestinal, so like nausea, vomiting, delayed gastric emptying. So I guess the main concern would be if the GLP-1 is giving you side effects that you're having trouble taking your sirolimus, but that would be a bigger issue also.
All right. Dr. Baqir, back to you. For someone with LAM who develops pulmonary hypertension, what treatment options are available and how is it typically managed?
So in LAM, the incidence or the frequency at which pulmonary hypertension happens is about, in the studies, it's quoted as 7% of the LAM patients. What happens is that with the cystic destruction, your oxygen goes down, and with hypoxia and low oxygen, that causes tightening of the blood vessels or pulmonary vessels that increases the pressure. And that's called pulmonary hypertension, or it causes increased pressure on the right side of the heart. It's not because of the problem with the pulmonary blood vessels themselves. So there is, in order to understand it, what is the cause, the expert in this area, the pulmonary hypertension specialist, they determine that what drugs to use or how do we treat pulmonary hypertension. So if the problem is within the blood vessels themselves, there are certain medications like sildenafil or endothelin receptors that work, and they dilate those blood vessels. But here, because we think the problem is because of cystic destruction and lack of oxygen, we want to treat the underlying problem. So the treatment would be sirolimus, giving oxygen, etc. Now, I think the data or results of using the drugs like sildenafil or endothelin receptor agonist, we don't have, the data is limited about that. So if we consider those drugs, that should be done in specialized centers. For example, at Mayo, we have a special clinic where the physicians are only day in, day out, they see patients of pulmonary hypertension. So I probably, if I would consider somebody, I would refer to them, that if they think that these drugs are appropriate. There are now inhaled medicines available, which there is more chance that they will improve the match between the healthy lung and the blood flow. So those can be considered, but again, that will come from pulmonary hypertension specialists. But from in my simple understanding, the treatment would be the treatment towards LAMP and to give oxygen and to treat other causes that can also contribute to pulmonary hypertension, such as blood clot or obstructive sleep apnea or other causes that can also make the oxygen go down in the blood.
Okay. Our next question is about someone that uses a CPAP machine at night with supplemental oxygen. She said that her LAM has progressed quite a bit since she started using it, and she's wondering if CPAP is considered safe for patients with more severe LAM.
Yeah, I think that's a very good question, and I actually had to consult our sleep medicine doctor for this question because what I read, there is no data to say that CPAP would make LAM worse. So the question is that this LAM lungs is made up of fragile cysts, right? So we give CPAP, which is positive pressure, which is you give some air to open up the collapsed airways, but there is a very little small pressure that we are giving, and that would be enough to cause further damage to those fragile cysts. So that is what the fear is, right? Mm-hmm. So in studies in which the CPAP was given to cystic lung diseases during surgery, they did not see that there was any increased risk of pneumothorax or further damage. But there is a theoretical risk that could cause some small cyst to rupture. It also depends on how advanced the lung disease is. If somebody has previous history of pneumothorax? Have they undergone pleurodesis? It also depends on those cases, and maybe if the requirement of CPAP is more than 15 centimeter of water, something like that, I think I would be a little hesitant and I would be a little concerned. But in general, there is no data that say that giving positive pressure or CPAP at night would cause LAM go worse. On the other hand, giving CPAP, if somebody requires, is very helpful because you eliminate the hypoxia or low oxygen that happens at night. You will have good quality sleep, and your chances of developing pulmonary hypertension that we mentioned before would be lesser. So if you weigh risk and benefits, the benefits are more for CPAP. But when I talked to my sleep doctor in detail, and he said that nowadays there are other options available, especially for mild obstructive sleep apnea or moderate, that you can probably consider like non-PAP therapies for obstructive sleep apnea. So I would think that if somebody is concerned that this is getting worse, or their LAM is getting worse, which in my opinion should not, but if there is a case or there is a concern, that they should consult their sleep doctors for other alternative treatment, which may or may not be available. At least they can consider those alternatives. For example, sometimes they advance the mandible in mild cases so that you don't have to use PAP for the treatment of obstructive sleep apnea. Inspire is a new therapy, but I don't know. You have to meet the criteria in which there is a hypoglossal nerve is stimulated, and that moves the tongue forward so it doesn't fall back. As I said, this is not for everybody. You have to meet their criteria, but they can at least be discussed with the sleep doctor.
So there's options, yeah. Okay. And then the last one for you, Dr. Baqir. I've been diagnosed for over 30 years. My FEV1 is now 35%, and I've been on oxygen for over 20 years. My physician has ordered a venous blood gas test. Can you explain what this test measures and why it's ordered?
I don't know why was that ordered, but I'm guessing that when you have your FEV1 goes down that low, there is a chance that you are not, what we call in medical term, ventilating well. That means that you're not getting rid of carbon dioxide, and you start retaining carbon dioxide. So that the blood gas gives, and carbon dioxide is acidic. So your pH actually goes down. For example, if a normal pH is 7.3, you could be 7.28, 7.27, something like that, and you start retaining carbon dioxide. So I think one thing that your physician probably is interested to know, that what is your pH, what is the carbon dioxide in the blood. And it also gives you, all the venous blood is not accurate for oxygen, but if it is arterial blood that you go actually into the radial artery, it also tells you your oxygen, like their accurate measurement of blood gases.
Okay, great. Dr. Higuero-Sevilla, are there any particular exercises such as heavy weightlifting that can cause a pneumothorax?
Right. That is a very good question. That made me think about mechanisms of why pneumothorax develops, but the short answer is the risk of pneumothorax in LAM patients come from the lungs themselves. Now, is there any specific guidance about exercising, weightlifting, and whether that will relate to a pneumothorax? Actually, there is not. That is not something that somebody has systematically studied. There was a paper of LAM clinicians about pulmonary rehabilitation and exercise in which the recommendation was that you've had a recent pneumothorax to avoid starting an exercise program for at least 4 weeks until your pneumothorax resolves. Now, mechanism-wise, what we worry in the patient with LAM is that these cysts are like fragile structures, and that's where they're more prone to breaking and causing the pneumothorax. So, of course, exercises that are going to increase your pressure inside of your chest a lot, things where you're holding your breath, and straining a lot, like lifting weights or very heavy exercise, can increase your risk of pneumothorax theoretically because you're increasing the pressure in your lungs. But again, there's no guidance that we can tell you like you should avoid this preemptively to reduce your risk of pneumothorax, because the risk is actually going to depend more on how severe your disease is. Have you had a pneumothorax in the past? But if you have a pneumothorax, I would recommend to avoid any exercises like that, any heavy exercise, any weightlifting until the event has fully resolved, probably at least 4 weeks after.
Okay, very good. And the next one was specific to one of our patients. I was diagnosed with LAM in 2014 after 2 spontaneous pneumothoraces. Following training and had a left-sided pleurectomy. In November 2025, I had another pneumothorax on the right side, again after training. Twice now, after cardio exercise, I've experienced extreme pain in my upper left back just below my shoulder. Could this be related to my prior pleurectomy?
The chest pain in the lung patients, one thing I say is multifactorial. Many things can happen. So, is it like like very small cyst rupturing from the strain to the point that are causing some discomfort, but not enough to cause a pneumothorax? But in patients that have had a surgery, we can see having chest pain even a long time after the surgery is something that can occur. Normally, after a surgery, you're going to develop adhesions, areas where your lung is stuck to the chest wall. So it is possible that if you create a lot of strain, specifically in that area, that you're going to irritate that area of the surface of your lung and have an episode of pain. We also know that the area of prior chest surgery, there can be irritation or damage to the nerve. So we see we see patients that have had the surgical interventions before have these episodes of chest pain. But if it's one episodic, self-limited, self-resolved, it's very unlikely that there's anything that's going to be done unless it's persistent. As the main thing that we want to be sure is that you're not developing a new pneumothorax, particularly if the symptoms are severe and persist.
Yeah, that makes sense.
Yeah.
Okay, and then the final one for you. Can you clarify the current flying recommendations for LAM patients? Is it necessary to stick to direct flights or multi-leg flights with multiple takeoffs and landings considered safe?
Yeah. So short answer is flying is safe for the majority of like LAM patients.
Mhm.
We don't restrict flying preemptively. So now you gotta individualize the recommendations to like how severe your disease is, how frequent have you had pneumothoraces in the past. What I will say is if you had a recent pneumothorax, you should not be getting on a plane until we know that the pneumothorax has resolved. Uh, some guidelines say 7 days after we know that the pneumothorax resolved on imaging. The other thing is if you're experiencing new chest pain or shortness of breath, you should not be getting on a plane until we know that you don't have a new pneumothorax. That's what we want to happen. But the rate of pneumothorax overall for LAM patients is very low. The number that gets quoted are 2 events for every 100 flights. Now, the multiple takeoff and landing question was interesting because, again, that's nothing that anybody has systematically studied. But if you think about it from mechanism of disease, so what's the problem with LAM in flying? So we go up on the plane, the planes are pressurized for about 8,000 feet of altitude rather than sea level. So
Mhm.
there's less pressure. So that volume of gas in your lungs can expand to about 30% more when you're in a plane than when you're walking around on the ground. So, and the areas of cyst in this front lung, in theory, that solution can lead to a pneumothorax. Now, interestingly, the expansion of the volume occurs when that's going to happen is during the ascent as you're going up.
Mhm.
So if anything, there's no data to suggest either or, but by mechanism, like the fact of going up and down multiple times would subject you more to the lung expansion than going up just for one long flight.
Mhm.
Yeah.
All right, Dr. Baqir, back to you. What type of birth control is considered safest and most appropriate for someone with LAM?
So just consider that this mTOR pathway, which is the culprit, just think that this is the engine of the car, which is already hot and it's already revved up, and you have added estrogen to it, which acts like the gasoline. So that's why we recommend not to give estrogen at all. No estrogen, no gasoline to make it further. Whenever there is high estrogen state, the disease really progresses. For example, in pregnancy, or it will happen if somebody is on estrogen containing oral contraceptives. So what to avoid completely, your combined oral contraceptive pills and contraceptive patches or vaginal patches. They have to be completely avoided. But there are certain safer alternatives, and the best options are if you use progesterone only IUDs or copper IUD, which does not have any hormone, and it is relatively safe to use. But there are other acceptable options as well. For example, progesterone only pills or progesterone implants and progestin injections or barrier methods. This would be the recommendation.
Okay. And then following that, my husband and I are trying to decide whether to start a family. What has been your experience with LAM patients who pursue pregnancy, and what key questions should we be asking as we consider this decision?
That is a very important question, and it's very deeply personal decision to have a family. I think that the short answer is if your lung disease is advanced and if your numbers are low, then I would say that you should avoid it. But otherwise, I have many patients who had children and without any problems. But having said that, I think we should understand that the studies have shown and the evidence has shown that because it's a high estrogen state, the lung functions decline, the risk of pneumothorax is high. And if somebody has angiomyolipoma in the kidneys or AML, they tend to bleed more during pregnancy. And even people have preterm deliveries, spontaneous abortions, and chylothorax during pregnancy. So all these have been studied. There was an NIH study about 300 pregnancy patients, and there is definitely increased risk of all these outcomes during pregnancy. Luckily, the neonatal outcomes or those who make it to the birth, they're not reported to have any bad outcomes. So I think the questions to ask before deciding about pregnancy is that what is your current lung functions like FEV1 or DLCO? Are you currently on sirolimus, or do you have any previous pneumothorax or had undergone pleurodesis, or do you have renal AML? And what is your pulmonary reserve, that if something bad happens, are you able to tolerate that or not? So all these questions depend on your baseline lung functions with this risk that this probably can get worse during pregnancy. And also, I would say that we have recently published, Nishant and others, we have collected cases where patients were on sirolimus and they continued sirolimus during their pregnancy, and they tolerated it okay. The pregnancy went fine, and the babies were fine. So that is something that is like, this was just a case report or case series, but more and more data would be available in near future as well, that maybe if somebody wants to be on sirolimus, maybe that would help preventing the loss of function during pregnancy, and that would be safe. Currently, if you look at the guidelines, it's a category C. Sirolimus is considered during pregnancy, that we don't have enough data to suggest, but I think in transplant world and our series suggests that maybe sirolimus is okay to continue during pregnancy.
Okay. And just as a note, I mean, I understand that's the scientific side of things. And whoever asked this question, if you do want to talk to another LAM patient that has had a baby while after diagnosis or while on sirolimus, the LAM Foundation and I can try to help you get set up with someone, because there are several that have had babies, started a family after being diagnosed, or continued their family after diagnosis. So
Good idea.
we're happy to do that. Okay, and then Dr. Baqir, on the other side of the coin, there are an increasing number of older women living with LAM. What guidance do you have for this group, and what can we expect as we age? Are there particular health issues or concerns that are especially important for older LAM patients?
Yeah, so as I said before, that LAM is very sensitive to estrogen and hormones. So that is one of the diseases where you want to be menopausal. And this estrogen, loss of estrogen helps in stabilizing the loss of lung function. And as I said before, the average rate of decline of FEV1 in postmenopausal women is around 40 ml per year. The decline doesn't stop, but it is way slower than premenopausal women. It's close to normal people. There is definitely lower risk of progression, low risk of pneumothorax, and better overall outcomes. Having said that, there are some people who continue to decline even after menopause. So therefore, monitoring is very important. You still need to see your doctor to have the breathing test done, and symptoms and oxygen needs and assessment for pulmonary hypertension. These things should continue even in postmenopausal stage. If the lung functions are declining, you still can get sirolimus. I think my mentor, which most of you know, Dr. Rue, is very much reluctant to give sirolimus to postmenopausal ladies, but I think that decisions are individualized in older patients. But there are other health issues that come with health with older people, like oxygen needs, obstructive sleep apnea, bone health, or heart health that should be addressed along with monitoring your lung functions.
Okay, great. Dr. Gupta, you get the final pre-submitted question, and then we'll open up the chat box. I was recently diagnosed with LAM and keep hearing people mention going to NIH. What are the benefits of being seen there? And would I go there in addition to my local LAM clinic?
Yeah, so the NIH has a long-standing program, a research program, plus an ongoing registry for LAM that's been there since the late 1990s, headed by Dr. Moss and his colleagues. Over the years, that has become probably the single largest resource for longitudinal natural history of LAM. With upwards of 800 patients worth of data and samples that have been collected. A number of publications have come out of those. A number of future projects are going to come off of those. So there is certainly value in going to NIH and contributing to LAM research endeavor that way. And yes, generally that is something you do in addition to your clinic, because your day-to-day management and the clinical management tends to be handled by your clinic, especially for people who have a significant amount of travel to go to NIH. So on the whole, I would also second this recommendation, and I would encourage people to go. If that is not practical, that is not fitting in your logistics, in your day-to-day life, is it absolutely essential? No. But if it can, I think it's always a good idea. And I think Cindy or Erin could probably give the date or the link to participants. There is an upcoming Lamposium in your living room session, I think sometime in March, that is going to be led by the NIH team, where they'll talk about their protocols in detail. So you can have more specific information and questions answered at that time.
Yeah, that session's going to be on March 12th at 7 p.m. Yeah, and it'll be Dr. Moss and the team from NIH going over the protocols. Okay. Thank you, Dr. Gupta. Are we ready to open the chat box? Looks like we are. The chat box is now open. We did have one question that we'll start with here that got submitted late about measles. The measles numbers going up, and if we should be looking into vaccinations and if they're safe for patients on sirolimus.
Well, the general idea for vaccinations is yes, vaccinations are good despite the world that we are living in. It's for taking a step back away from measles. For all LAM patients, we recommend that you get your flu shots, that you get vaccinated for pneumococcus. If you're older than 60, you get vaccinated for RSV, you get your COVID vaccines as per the national guidance. And shingles vaccine if you're older than 50, or if you're going to start or be on sirolimus, irrespective of your age. Now, I have to jog my memory. I'm trying to remember if the MMR vaccine is a live vaccine or not. But that's the one. It is a live vaccine, I think. So that is the one concern you would have, is that you shouldn't take a live vaccine if you're on sirolimus. Because a live vaccine means that you're getting a small concentration of the bug itself to rev up your immune system. And in a reduced immune state, like someone might be, if you're on sirolimus, we don't want to give a live vaccine. So if you're not on sirolimus and you haven't had the MMR vaccine, absolutely you can. If you're on sirolimus, that's a discussion that you need to have with your LAM clinician to talk about whether you should get vaccinated or not, or you should whether you are in a state to hold your sirolimus to get vaccinated, etc.
Yeah, measles is a live vaccine. So, and the recommendations are to avoid it if you are on sirolimus. I do not think that, because I was reading our statement on vaccination for LAM patients, and in that it's written that some of these medications should be temporarily held, but I think live vaccine should be avoided, not that you hold sirolimus.
Yeah. That has come up. Well, that's a very good question because we haven't had to deal with it. But when we had patients that need a live vaccine that are on other immunosuppression for connective tissues, is that is an issue. So normally we would need a washout period of at least a couple of weeks to even consider doing it, which is again a risk-benefit discussion. But a lot of patients, we would check them for prior immunity if there's a concern, to see if they have detectable antibody levels before we consider vaccinating them.
Okay. And you can just get a blood test to see what your levels are.
Yeah.
Okay. All right. Looks like we have some questions in the chat box now. What is retroperitoneal? I don't know if I pronounced that correctly. LAM, and what % of LAM patients have it?
Retroperitoneal LAM is, I think it is a collection of what you call lymph tissues in the part of the abdomen which is below the where your organs are. That is what the retroperitoneum means. So that can happen in LAM. It's basically another manifestation of lymphatic problems that happens with LAM. The percentage, I am not 100% sure the exact percentage. I'm thinking it is around 10%, maybe. What do you think, Nishant?
I think that's fair. Somewhere between 10 to 15%.
Yeah. Yeah. So basically, it is one of the complications of the lymphatics that I mentioned before. That it's a collection of lymphatic tissue that cause kind of growth in that area. And recently, I had a patient. I gave sirolimus, and with excellent response to shrinkage of that tissue.
Okay. Do you ever see elevated liver function values with sirolimus? And is it ever seen in the first several months of therapy?
So liver toxicity can occur. It's not one of the common things we think about, and it's usually mild. But whenever we see liver toxicity, we also gotta make sure that there's no other cause, uh, like viral hepatitis testing or other reasons that would explain it, because it's not one of the common symptoms. And if it's with sirolimus, it tends to be mild. I don't know if Nishant or Misbah have a different experience.
Yeah, similar experience, JP. We don't tend to see it commonly. It can happen for very mild elevations. We typically would recheck and not interrupt therapy or reduce dose. I have once or twice we've had patients with significant elevations where we have had to stop therapy. But it's very uncommon.
Okay. Sorry, my screen jumped here. Is it safe for lab patients to use a PEP buddy positive expiratory pressure device? It seems similar to pursed lip breathing.
Yeah, maybe I should take that, considering it's a Cincinnati device coming from our division.
You could take that one.
So this device was made by one of our colleagues here named Ehsan Zafar. And what it is, it's a sort of a simple 3D printed a piece of plastic with a hole or a couple other holes at the end of it that you can sort of wear the lanyard. And I guess the simplest way to describe it is it's a whistle that doesn't whistle. Okay.
Wow.
And the idea being that, as someone said, it's similar to pursed lip breathing in COPD. You're just trying to put a little bit of back pressure as you're exhaling to keep your airway stented open and allow you to properly exhale the air. It's helpful and studied in patients with COPD who have dynamic hyperinflation, meaning they can get the air in fine but can't get the air out as well. In some patients with LAM, that dynamic hyperinflation is the physiology why you get short of breath or why your oxygens may drop with exertion. So theoretically, could it be helpful in that circumstance? Yes. But it hasn't really been tested in patients with LAM, so I don't think that's something we can make broad recommendations for. We had thought about, made a plan for doing this study in LAM. It just has never really got around to it. It's along the massive to-do list of things that I need to get to. But yes, there is not a whole lot of harm in trying it if you want to try it, but I would probably talk to your physician first to see whether you have evidence of air trapping, etc. There probably isn't a whole lot of downside to it, but keep in mind, it hasn't really been tested in lab.
Mm-hmm. Very good. Okay, the next question, I'm not sure if the doctors are going to be able to assist with. Why in Ontario hasn't the OHIP drug program recognized sirolimus as a treatment for LAM? Is that something you're familiar with, or should we take that as a follow-up?
Yeah, probably the latter. I'm obviously not familiar with the healthcare regulation aspect of things in Canada, but I know a couple of the clinicians in Ontario, and I know that they are writing for sirolimus, and that I know of patients who are taking it. So I'm not aware of the exact mechanism by which they're getting it, but
yeah, I think they're concerned about the cost, right? Because private drug programs won't cover it. Okay, Aaron or Cindy, would you mind taking a note on that so we can follow up?
Yeah, of course. Sorry.
CRISPR question, our annual CRISPR question. Is there any research being done with CRISPR? I assume they mean for LAM.
Yeah, I mean, is there research being done with CRISPR? So, well, let's take a step back. CRISPR is sort of the gene editing tool that has a lot of promise, is being used successfully in other diseases already and coming to the clinic. The hope is that, yes, can you have that gene therapy be relevant or applicable to lamb someday? Yes. Is it ready for prime time now or even in the short term of 5 years or so? No. There are a lot of issues with sort of, because you want to have this be directed just to your lamb cells, and it is difficult to do that. Uh, will it get there someday? Yes, I hope, but it's not there yet.
Okay.
I think we had a question a few years back on CRISPR too, and I remember Dr. Dillon was there. The problem with the gene therapy is also that in sporadic lamb, it is not all the cells which has the mutation. It is only a few affected cells as compared to tuberous sclerosis, which is because it happens before you're born. So all cells had that mutation. So I think that the major limitation with CRISPR is that you have to select those cells which have that mutation. You can't apply it to all the cells because they won't have it.
Yeah, that's what I remember him saying too.
Yes.
All right. Do we have any data on lamb patients that have needed a lung transplant? It's kind of vague, but maybe number of patients that have needed, number of lamb patients that have needed lung transplants?
There have been studies on transplant patients with lamb, but I don't know what the exact question is.
Yeah, maybe if you want to, go ahead.
Just to say broadly, like in general, like patients with lamb have a better overall, much better overall survival than the average lung transplant patient. And
Okay, yeah, if there's additional details you want to add to that question, you can do that. We'll come back to it. Okay.
I am with sporadic lamb, and I am waiting. I am in the waiting list of transplant. I wait to call me. So I am in the oxygen also, and I wait for a transplant. So I am the patient that I wait for lungs.
Okay. Did you have any other specific details you wanted to understand?
Me?
Yeah.
No, I want to ask something about the food. We have to with sirolimus, because I was in sirolimus. The food that we eat, if there is any food that we can avoid, and during the sirolimus or lamb patient.
So foods to avoid for if you have lamb or if you're on sirolimus.
Yes. About food, we have to avoid some food. I don't know. Here in Cyprus, we don't have a specialized here.
I think grapefruit is one of them.
If you're on sirolimus, grapefruit, yeah.
Now the sirolimus increases there are certain drugs which are metabolized. If you're on sirolimus, then this SIP, whatever that pathway is, that there are certain drugs which are metabolized. But among the food, grapefruit is the one that should be avoided because it increases the level of sirolimus.
Okay, thank you.
Okay. And then I think, do we still say don't eat too much soy in moderation?
The soy question is always very tricky because the amount of estrogen that is available after having soy is you have to eat a lot of soy to increase your estrogen level, like tons of soy. So that is why people think that it is okay to eat soy.
Yeah.
And then I guess supplements, because it's like Saint Jordan's Wort, like you said, with CYP inducer. So be careful about that because they can drop your levels of sirolimus. I always tell my patients, if you're gonna start taking any supplements, would you like let us know, and I'll have my pharmacy team check to see if there's any reported interactions.
Good. Okay, so is estradiol vaginal cream for atrophic vaginitis safe for use in postmenopausal patients with significant UTI history?
Yeah, the estrogen cream is okay. The studies have shown that it doesn't decrease or increase the blood level of estrogen. There is also in the Lamb Foundation website, there used to be, I didn't check that whether they have it. There were some videos about women health. And one thing that they recommended was another thing other than this vaginal cream was, I'm going to spell it, IMVEXXY, which is probably vaginal tablets. I'm not sure in what form it comes, but that is also one that can be recommended if somebody is undergoing vaginal atrophy.
Okay, good. And there's a note here, someone followed up on the Ontario sirolimus question. I live in Ontario and I am on sirolimus. My health coverage from work covers it all, but my doctor also told me if I didn't have coverage that he could talk to OHIP to cover it, so talk to your doctor about it. So whoever put that in there, just so you know. I was diagnosed 10 years ago with LAM and it was quite advanced then. I like to walk as my main exercise and have noticed recently it's harder for me to breathe even with a POC. Is this just because of aging or are there other changes happening to my lungs or am I just out of shape?
And I think that's a hard question to answer without having like the background clinical information, because it would need to be like, are your lung function tests getting worse? Do we have any evidence that you have a declining like significant decline in your lung function? Or well, it could be just the conditioning, but we cannot. It's hard to answer without more clinical information.
Yeah. Okay, I'm currently awaiting VEGF-D results. I newly diagnosed 2 years ago and had a lumpectomy on my left breast. Just learning that the LAM cysts are estrogen and progesterone positive, the same as breast tumors. Are there many LAM patients that have had breast cancer, and is there possibly a connection?
This is a question that comes up frequently. There have been a couple of studies that have been done that sort of suggested a potential link, but there were significant methodological flaws with those studies to where I'd say the jury is still out on whether there is a connection. I just anecdotally and per our experience, I really haven't seen any consistent link between LAM and breast cancer. Breast cancer is a very common malignancy, so it stands to reason that there are going to be some patients where you see this together, but I'm not convinced that there is a systemic increased risk of breast cancer in women with LAM.
Okay. Good to know. Can we take antibiotics like penicillin and amoxicillin and sirolimus at the same time or the same day?
I think we can, but does anybody has any?
Yeah, and
Yeah,
I'd second what Ms. Pa said. I don't know the context of this question. Is this sort of a drug question? Can you take them together? Yes. The other layer to this question might be, do you need to hold your sirolimus just because you're on antibiotics? And I think that depends upon the reason you're on antibiotics and how severe that infection is. Generally, if you have a milder infection, I'd say that we try to power through and say if we can get by without holding sirolimus, we will. But if it's a more severe infection, then we may need to hold sirolimus for that purpose.
and I will say, because I looked it up just now, like Penny, from the can I take with sirolimus point of question is any new drug that you're gonna take, like you should check that it doesn't have interaction with sirolimus. So that's where the clinic support comes in, because amoxicillin doesn't have an interaction with sirolimus, but your primary care or somebody else might try to prescribe something that could have one. So it's something that always needs to be checked with pharmacy.
Okay. Can hormone replacement therapy flip a switch in postmenopausal women and initiate LAM?
Yeah, that's one of the things that we worry about, exogenous estrogens in LAM. So normally recommend to avoid any estrogen, because we know of the correlation within like estrogen and disease activity.
Yeah, and if I might just add, if the question is, can hormone replacement therapy sort of de novo lead to someone developing LAM? Probably not. We, as everyone here has already said, we worry about the estrogen exacerbating or accelerating the progression of LAM, but we don't think that that's gonna suddenly sort of lead you to develop LAM.
Yeah.
That's a good clarification.
Yeah.
Okay, I'm on sirolimus. Should I be getting pneumococcal vaccines?
Yes.
Period. I don't think any of them are live, are they?
No, that's pneumococcal vaccine is not a live vaccine.
Okay. I was diagnosed after menopause. Recently, I showed bone lesions and had a bone biopsy yesterday. Have you seen bone lesions before, and could it be a mosaic LAM? Could I be a mosaic LAM patient? My PFTs have been great since diagnosis, and my kidney lipomas have not grown, but my white cell count has been low, though I rarely get sick, and my blood calcium has been elevated and vitamin D low. Not sure why.
Bone lesions means, what do you mean by bone lesions? Like, we don't know what they are?
That's all she said was bone lesions. Sandy, I don't know if you want to clarify if you're still there. Oh, there's Sandy. Oh, I can't hear you, Sandy. You're muted. No, still can't hear you.
Okay, I'm here now.
Yeah, you're there.
My last MRI in May, it suddenly showed numerous bone lesions on my pelvis and like spine and things. So my LAM doctor wanted me. I did go to a hematologist. Nothing came out of that. They're thinking possibly sarcoidosis, though I have no other symptoms. So I had the bone biopsy yesterday. I'm waiting results to see if it shows anything. I know another LAM patient exactly like me who also has the bone lesions now and the high calcium. So it's kind of unusual. She goes to NIH in March, so I'm hoping she can get some answers, and then maybe I'll know more too.
I think sarcoid is very relatively common disease, obviously compared to LAM. So if this is sarcoid, which is responsible for, first of all, we don't know what the bone lesions are. But once we know the biopsy, and if this is sarcoid or granulomatous disease, which can explain your low WBC count, etc., for that you need bone marrow biopsy. I don't know what. Anyway, so if it is sarcoid, it can happen that the LAM patient can also have sarcoid, and that is treated differently, sometimes with steroids. But obviously, we need to know what exactly are these bone lesions.
Okay, great.
Okay. Can LAM be treated with immunotherapy?
Not at this point, just because we haven't had a clinical trial that has suggested so. But immunotherapy is definitely amongst the probable targets that are ripe for translation. There has been research from Drs. Hensky, Dr. Krimskaya, Dr. Borchers have all suggested different pathways by which LAM cells evade the immune system. And immunotherapy is commonly used for other forms of cancer. So I think it's plausible to think that might have a role to play in LAM. But we really have to test it in a trial, especially given that immunotherapy can also have significant side effects, especially pertaining to causing inflammation and injury to the lungs. And so in a existing lung disease, we need to be careful about that. So until and unless we prove this in a trial, at this point, I'd say the answer is no. But is it a potential treatment for the future? Yes.
Can there be issues with physical contamination to other family members or sexual partners when on sirolimus? No.
I'm not aware.
No.
Yeah,
I
neither
haven't
am
heard
I.
that.
And Sharon, you may need to assign people with questions.
Okay, I can do that. I was diagnosed with Lyme 5 years ago. I also have tubular sclerosis. Lately, I've been having pain in the lower groin area. MRI, etc., are relatively negative. Could this pain be related to Lyme? Dr. Higuero-Sevilla, you want to answer that one?
So if normally if there was a lymphangioma or something impinging in the area that's related to Lyme, then that would explain it. But if imaging doesn't show anything, then it's hard because there could be other causes of pelvic pain. So without any imaging abnormalities, I could not say that it's like related to Lyme if we don't see anything.
Okay. Dr. Baqir, oxygen is important to our brains. Are there any studies about whether having a lower resting saturation of 90% without oxygen has any impact on development of dementia later in life?
Well, I don't think so that there are studies. I'm not sure about them, but 90%, 88 and above or 90 is what we usually want to see. That we don't want to go below 88% or 90%. So, but I'm not aware. If somebody else is aware, please let me know about the studies of dementia, and I'm not aware.
Yeah,
No.
second, what Dr. Baqir just said, I'm not aware of any data. This is also a question and a topic that would be difficult to conclusively prove or disprove one way or the other. But at least we are not aware of any risks.
Okay. All right. Dr. Gupta, Sarah said here, to respond to your comments, there is a trial currently enrolling LAM P2 with I don't know what that is. LMA.
Yeah, I think that the LAMP trial was the imatinib trial with Doctors Darmiento and Goldklang. So good to know that LAMP True is enrolling. Thanks, Sarah, for notifying us. And if I could also make a request, since if it is enrolling, perhaps if Doctors Darmiento or Goldklang could reach out to the foundation, that could perhaps be put on the foundation's page for patients to generally be aware of.
Mm-hmm.
Yeah, I CC'd the doctors on an email to Sharon.
Okay.
Well, could connect.
Thank you.
Great. Thank you.
It is not on the clinical trial page on LAM Foundation.
Yeah, we'll have to get that information to the LAM Foundation so they can work with it. Okay, and then Sarah had a question about what are potential treatments for menopause given our estrogen restrictions?
For menopause, the question is, so with menopause, there are three things that happen. One is the mood disturbances or depression. The other is that you can have atrophy of vagina and sexual health is affected. And the other thing is that bone health or loss of libido. These are the things that are affected, and every part of it is treated differently. That whether you are asking about vaginitis, are we asking about depression, the mood swings? So if somebody can be more clear, I can tell more, but it's a broad topic. It's a whole topic in itself that just postmenopausal is a broad term.
Yes, the brain fog that comes with perimenopause, the hot flashes. I've been told that magnesium, 400 milligrams a day, is basically our only option. I wondered if there are other opinions.
Yeah, so I know that this question comes every year in this, so I have actually made notes, and these are actually, they were available. I didn't check recently. Lisa Larkin was the LAM Foundation lady who takes care of women health, or she used to. I don't know whether it's still there. But for hot flashes, what she recommended in her talk on women health was that first of all is the lifestyle changes, that wearing the layered clothes. So if you are feeling hot, you can take off the the layers. That is like simple things to do, and I think you would know already. But there are some mixed results from if you think about holistic approach, that acupuncture is one thing that she said that there are mixed results trying that for hot flashes. But there are certain non-prescription supplements which she mentioned. For example, vitamin E or red clover and kava, Kava, kava leaves. These are non-prescription supplements. But then there are certain non-hormonal medications, which, for example, Effexor or Neurontin or antidepressants, they also take care of the hot flashes, especially improving the sleep, and oxybutynin is also effective in that regard.
Thank you.
I'm not sure how familiar any of you are with oxygen concentrators. I don't know if one of you can pick this one up. Is there an oxygen concentrator for someone who likes to travel but needs it for sleep as well? Otherwise, maybe that's one we can take back to the follow up on afterwards.
Yes, I'm not, unfortunately, I'm that a lot of that is managed by our clinic staff and our medical supply person, the different available equipments, which a lot of are also limited by insurance and portability size. So I'm not sure. I don't know.
Yeah, I think that's typically how it works. Okay, so we can take that back. I know we've had sessions on oxygen, and maybe we can follow up and get some more answers on that.
I could say something and then I'll mute myself. I like Inogen for travel.
Yeah, I've heard a lot of people say that.
Yeah.
Thank you. Are there ways to reduce high red blood count and low MCV? My MCV is always low, but my RBC was around 5.48 on my last blood test. Dr. Higuero-Sevilla, you want to take that one?
I am just not sure if of this question, how it would be related to LAM. Low MCVs would suggest microcytosis, but then if you're having higher BC, I assume you don't have anemia. I would not know if this is something LAM related or how to interpret like those values in isolation.
Okay. All right. So maybe follow up with your physician.
Yeah.
Okay. All right, Dr. Gupta, since LAM is a lymphatic disease, can you briefly review how lymphatic involvement typically presents and what symptoms would warrant further evaluation? From a monitoring standpoint, what clinical signs suggest meaningful lymphatic involvement versus benign reactive lymph nodes?
Yeah, that's a good question and an important topic. So I'll try to simplify it. So if you think about it, that LAM cells are starting somewhere, and then they travel up the lymphatic system to reach the lungs. So if you think about it from a simple plumbing issue, there is a pipe and there is a blob of cells that is going through that pipe before it reaches the lungs. So as sometimes that blob of cells can simply just block the flow of lymph through that pipe. As and when and if that happens, that can cause the fluid that was otherwise supposed to go through the pipe now will have to leak behind. And that can create a complication where lymph or chyle can drain into wherever it can find an exit space. Commonly, it happens to be around the pleura or the lung linings, but it can also, in rare cases, happen in the lung. In some cases, it can happen in the abdominal cavity. So that's a sort of a chylous leak being one of the lymphatic complications of LAM. Other lymphatic complications of LAM can be that you have enlarged lymph nodes, typically around the same pathway. And the third is that sometimes you can have these collections of lymphatic fluid, most commonly in their abdomen, but can happen in other areas as well. How common is it? In women with sporadic LAM, lymphatic complications can be seen in about 15 to 20% of women with sporadic LAM. For reasons that we don't fully understand, lymphatic complications are quite uncommon in women with TSC LAM. And almost all lymphatic complications in almost all patients respond remarkably well to sirolimus. And sometimes, especially for effusions and chyle leakages, it may take a few weeks to even a few months, but it generally respond very well to sirolimus. And we have had horror stories where women have had invasive procedures done to manage these leaks. And generally, our stance is if you have a clinically significant lymphatic complication, it should be managed with sirolimus, and surgeries or procedures should be reserved as a last resort.
Mm-hmm.
And I think that answered most. Is there any part of the question that I didn't answer?
Nope, I think you got it.
Okay.
Okay. Dr. Baqir, can you speak more about pelvic floor dysfunction in lamb? Was told it's being studied by someone and wonder if there's an update. Do you know anything about that? Otherwise, we might have to take that back.
I'm sorry, I don't know that it has been studied. I don't know anybody.
Anyone else?
Or
I can add to that. This is Cindy from the Lamb Foundation. We had two researchers that did study on pelvic floor health in lamb and presented last December, I believe. I will put a link in our chat here on where that video can be accessed so folks can learn more there.
Perfect, thank you.
Mm-hmm.
Dr. Higuero-Sevilla, are small lung nodules more common in lamb patients?
That's a good question. So small lung nodules are actually like a very common finding in general populations whenever we screen somebody. So the lamb typically will present as lung cysts, but you can see some small nodules in certain patients with lamb, particularly in patients that have like tuberous sclerosis. But is there an increased risk of any type of lung nodules any type of lung nodules in patients with lamb? I could not say that because just other non-lamb related lung nodules are actually a very common finding. You scan multiple patients and you'll find it small nodules for many other reasons. But then that takes the clinician to discern whether what they're seeing is this something I think is related to the patient's lamb or is something different that's just gonna need follow-up to make sure that are not growing. Because for lamb, generally we don't monitor lung imaging serially. As Nishan said, there's cyst scores and things that are not part of standard of care. But if we find lung nodules that we think are from any other reason, then that will require follow-up.
Okay, good. Cindy, did you see the message about potentially doing some kind of educational session on menopause and hormone replacement therapy?
Yes, we already have that set up. Actually, we'll be having a session on that in August, so folks can watch for that.
That's fantastic. Thank you. Thinking ahead. Can you explain I'm sorry, who wants this one? Dr. Gupta, can you explain what mosaic lamb is? I've never heard of it. I have a lot of bone issues. I have non-hereditary lamb.
Yeah, let me see if I can try to simplify it in the couple of minutes that we have left. So, generally we think of a lamb as a very dichotomous bucket of sporadic lamb or TSC lamb, right? And the distinction between these two buckets being that in TSC lamb, every cell in your body has the mutation, and that mutation can be passed along from one generation to the another because every cell in your body has it. Sporadic lamb, we say that you don't have this mutation in every cell. This mutation is limited only to the cells that are causing the disease. And because it is not present in every cell, that is not something that can be passed along from one generation to another. Mosaicism or mosaic lamb, if you will, is sort of think about this as an in-between category of the two. So the general idea being that not every cell in your body has the mutation, but that some cells, as they are dividing, start harboring this mutation to where a percentage that could be single digits to less than 50 might have this mutation. And so depending upon at what stage it was acquired and how many cells have it, your features can be similar to sporadic LAM or start morphing a little bit towards TSC, but not full-blown TSC. And can that have risk of hereditary transmission? Not as much as TSC LAM, but theoretically that risk is there. Having said that, I will say that in the absence of TSC LAM, I'm not aware of a sort of generation to generation transfer of LAM. So how much of a practical risk that is, that remains to be seen. Take it to the extreme, you could argue that is every case of sporadic LAM some sort of a mosaicism? Maybe that's sort of an extreme end of that theory. So think of mosaicism as somewhere between sporadic and TSC.
Okay. All right. We're going to do one more question, and then Erin, are we able to capture the ones that are left so we can follow up?
Yes, I'll be saving them and we'll follow up.
Okay, so this one is for all the doctors. What message of hope or perspective would you like patients to leave with today? Dr. Gupta, do you want to start?
Sure. A lot of patients have heard this from me ad nauseum. So if this is sounding redundant, I'm sorry. If you haven't heard it, great. Look, I will always tell patients with LAM that there's every reason to be hopeful. There is every reason to be optimistic. The future of LAM is bright. We started this meeting with this sort of the perspective that we have an FDA-approved therapy for LAM. We have a blood-based diagnostic biomarker for LAM. We have clinical practice guidelines for LAM. We have a clinic network that spans the world. Not a lot of rare diseases can claim to have even one of these things that we have. To top that, we understand the biology of LAM. We know the mutation that causes it. We know the pathway that is involved with it. That pathway, as it turns out, is central to a number of other diseases and is being studied by the world's best minds. With the technology we have now, we understand LAM at a very high resolution. We already have multiple targets that can be tested in the clinic. We have an organized community, both from a patient standpoint and a physician standpoint, and you have a wonderful organization in the LAM Foundation sort of advocating on your behalf. So put it all together, we have everything that we need to make further progress in LAM, and the pace of progress in LAM is unparalleled, and I would say it rivals any other field of medicine that you could take a look at. So if you put it all together, and that's what makes me say you should be hopeful, you should be optimistic, and that the future of LAM is bright.
Great. Dr. Baqir, you want to go next?
I would second what Dr. Gupta has said beautifully. I would say that, so whenever I attend LAM meeting, like last one was in Kansas, you always come out very, very hopeful and thinking that there are so many great minds working on one rare disease and trying to find the solutions, and even seeing patients there contributing and immensely interested in the field. So one thing is that once the basic scientists, they explore more targets, for example, immune therapy, etc., I think when it will be time for clinical trials, we really need patients' help. That is where you are important. You're always important, but you will be very important to participate in the trials so that we can help the field go forward, and something comes up on the market for better treatment. But I am very, very hopeful that in near future there would be more drugs available.
Great. Dr. Higuero-Sevilla, you want to?
Well, just to echo what Ms. Va and Nishan said, which I completely support. I will say just that LAM, I think, is no longer this ultra rare disease. We're starting to recognize that it's more prevalent, and it's no longer a mystery in the medical community. like people are recognizing it more and more and like saying, oh, this is what I suspect, and sending to the lamb clinics. And that all has to do with the patient, like the increased awareness, particularly from all the great work with the Lamb Foundation and this very involved community. I will say, for somebody that started the Lamb Clinic just a couple of years ago, the amount of support that we get is amazing. And having attended my first Lamposium in Kansas, it was a beautiful experience. So I would say, if you're coming into LAM now, you're coming into an era of a disease that has a treatment that people are knowledgeable about, that there's more being done. And with the era of precision medicine, we expect that the treatments are only going to get better, and the disease courses are just going to continue to improve for women in the future.
Fantastic. Well, that makes me feel good. I hope it does everyone else too. All right. Anything else any other pearls of wisdom you guys want to leave us with before we wrap up here?
Thank you
No?
for the excellent talks by others and the questions that are put forward. Every year it gives me, I learn more and more. These questions are excellent. I really give credit to the LAM ladies who ask these questions. They're very thoughtful.
Mm-hmm. Absolutely. This is one of my favorite days of the year, to hear all the questions that people have, and the great insight that you guys bring to us. So thank you. Thank you for your time and everything that you dedicate to the LAM community. We all really, really appreciate you. So, and Cindy and Aaron, thank you too for your time, and all of you for spending your morning with us. Thank you.
Thank you, Sharon.
Okay, have a great weekend, everyone. And Region 12, I'll be reaching out soon. Take care.
Bye-bye.
Bye.